Now that we completed central nervous system stimulants, this chapter 21, goes into the central nervous system depressants. Most of these depressants deal with anxiety, and a lot of them with sleep. So understanding our sleep, there's the REM, or rapid eye movement, and the non-REM. Both REM and non-REM occur cyclically during sleep at about 90-minute intervals. The period of REM sleep episodes becomes longer during the sleep process. If sleep is interrupted, the cycle begins again with stage 1 of non-REM sleep. It's difficult to arouse a person during REM sleep. Individuals perform better during their waking hours if they experience all types and stages of sleep. Most of recallable dreams are experienced during the REM sleep. If a person is roused from REM sleep, frequently a vivid, bizarre dream may be recalled. Sleep disorders. Insomnia is more common in females, often treated with sedative hypnotics. One of the things you want to work with patients is because these sedatives and hypnotics are supposed to be short-term. Unfortunately, they're not prescribed that way, although they should be. So non-pharmacological recommendations teaching is not taking any daytime naps, drinking warm fluids close to bedtime, no caffeine for 6 hours before bedtime, avoiding heavy meals and exercise within a couple hours of sleep, taking a warm bath, reading, listening to music. I've recommended to patients to have like a noise such as a noisemaker, because it needs, if it's listening to music, it needs to be more of a steady tone, because the inflections of voices and things, so music is okay, like rain, waterfalls, but things with voices, the inflection of the voices disrupts that REM sleep. You should have a routine and a set time. So, sedatives and hypnotics being used for sleep. They're very commonly ordered, and unfortunately they're abused. Their purpose is to diminish the physical and mental response at the lowest level. There's $35 million a year spent on over-the-counter sleep aids. The over-the-counter sleep aids all have diphenhydramine or Benadryl. If you look at them, we've covered diphenhydramine in a previous chapter, and if you will look on the labels of them, you'll see 50 milligrams of diphenhydramine, which I find I can't take it. It makes me feel like I have a hangover in the morning, because it lasts a long time. So the classifications we're going to talk about are barbiturates, benzodiazepines, and non-benzodiazepines. So, barbiturates. The barbiturates are classified as long-acting, intermediate-acting, short-acting, and ultra-short-acting. As we discuss them, we'll talk more about them. I don't need you to memorize which they are, just be familiar with the drugs. And barbiturates should be restricted to short-term, 2 weeks or less, but once you get out and start working, you'll see that unfortunately is not the case. So this is a list of several benzodiazepines that are often used. They are in your text on table 21-2 on page 294. I've seen every one of these ordered. It's interesting that Halcyon or triazolam is no longer prescribed in Europe. I thought that was interesting. It's still prescribed here. One thing to notice in table 21.2 is every one of these are a pregnancy category D, which would be not to take, because the category C is weighing out risk, so they should not be taken during pregnancy or childbearing if they're trying to get pregnant. Several of these also can increase the risk for suicidal ideation, so that should be something, if they have a history or of any suicide, they should not be given. And also some teaching with the patient, if they're having suicidal thoughts, that it need to be reported immediately. Short acting, well, if you see, oh, where did I go? Yeah, if you look on this chart with the short acting, it's interesting on the half-lives of all of these, like even the short acting ones, the half-life is anywhere from 4 to 50 hours. Intermediate acting are 100 hours. And, yeah. And down here on the long acting is even longer than that. I mean, they're all like 50 to 150 hours, which is pretty crazy. Alprazolam, which you've heard of course, as Xanax, which unfortunately is a drug that is on the streets and very, very, very abused. They have a prototype, chart 21.1. It is a category D. The max of 10 milligrams a day. Contraindicated with respiratory depression, acute alcohol intoxication. That is one teaching when you have a patient on alprazolam or prescribed that, not to take any alcohol. It has a terrible, actually very severe drug interaction, and they can have a respiratory arrest. Caution with older adults, those with sleep apnea, renal and liver problems, suicidal ideation, any history of drug abuse. And as many of the others, it decreases respirations with alcohol. Also, it interacts with the antifungals, which the azoles, cimetidine, which many drugs do, rifampin, digoxin, and some of the seizure meds like phenytoin. Interestingly, that it has a grapefruit increases alprazolam levels, green tea decreases alprazolam levels. A good teaching thing there. Adverse reactions are depression or impaired coordination. This is how they work, interacting with the neurotransmitter GABA to reduce neuron excitability. I'm getting tongue-tied. They are all a Schedule 4, and they're controlled substances. You can, let me see here, let's go to the next one, treating anxiety and insomnia. So there are people that will take this several times through the day or just take it as needed, but there are people that are very dependent on it. So the nursing process, you have that also in your text, starting at page 294, going all the way over to page 296. You would want to look over that. You will get their history. Are they taking for insomnia and anxiety? What other measures have been used? Discussing dizziness, hypotension, not operating a motor vehicle. They can have confusion, especially in the older adults. Try to teach other methods to help with sleep and anxiety, avoiding alcohol, which I touched on. And there is an herbal alert On page 297, 21.1, Kava should not be taken in combination with any central nervous system depressant such as barbiturates and opioids. It increases the sedative effect. And valerian, which people take valerian root, when taken with alcohol and other central nervous depressants such as barbiturates, may increase the sedative effect of the prescribed drug. That's significant. Advise them not to drive. I said that. Check with healthcare provider, and it should not be stopped abruptly. It has some good safety alerts on phenobarbital, which is different than pentobarbital, which is an anesthetic. And then on another page, lorazepam and alprazolam. Lorazepam is a benzodiazepine. Alprazolam, they're both benzos. One's for anxiety and insomnia. So non-benzodiazepines are on page 297. Zolpidem, you will know as Ambien, but you need to learn it as Zolpidem, is a non-benzodiazepine for short-term treatment, less than 10 days of insomnia. And again, people stay on these. Duration is 6 to 8 hours, metabolized in the liver. It has the prototype chart 21.2. It's a category C, interacts with antifungals azoles. It decreases the levels of rifampin. It should not be taken with alcohol. Caution with renal or liver disease, suicidal ideation, pregnancy, older adults, and debilitated. The side effects: drowsiness, lethargy, hot flashes, a hangover sensation, visual disturbance, irritability. It does develop a physical, psychological tolerance and dependence. Can cause suicidal ideation, hypotension, angioedema, which is swelling in the oral and throat. One thing that's not listed here, which actually is fairly common, where patients talk about having, they sleepwalk on Zolpidem. I've seen that in numerous patients. I'm surprised it's not listed because it's fairly common complaint. Teaching, first using non-pharmacological methods, attentive to safety, avoiding alcohol and other central nervous depressants. Take 15 to 45 minutes before bedtime. Report if they're getting a hangover effect. They should monitor their blood pressure, respiratory rate, and gradual withdrawal, not abrupt. Okay, sedatives and hypnotics in older adults. Definitely want to find out what is causing the sleep issue and try to get to the root of it and discuss non-pharmacological methods, because all of these should be short-term use. In the older adult, they can cause an increase in their central nervous system depression. It can have confusion. It can put them at risk for falls. Avoid some of these benzodiazepines, the short and intermediate acting, the long-acting benzodiazepines that are listed should be avoided in the older adult. And encouraging the older adults, if they need to take benzodiazepines, to take them just a few times a week. Nursing process, page, let's see, starting at the bottom, page 297 onto 298. It's just things we pretty much covered in the others. Always to make sure they're going to be able to get 8 hours sleep when they take it, bed alone with the older adult because the risk for falling, all the respiratory depression, everything we've covered there already. It's interesting. Oh, melatonin agonist. I forgot about this one. Okay, the melatonin agonist, it's interesting. I have not seen that. It's very new. Because I know people do take, and I have encouraged them to take melatonin over the counter. Our brain does release melatonin, which helps with our sleep, and so it's good to see that where melatonin is now available, because it's a melatonin agonist. So it's like a sympathomimetic. It works like the melatonin, encourages the melatonin. It's not classified as a controlled substance. It's selective on targeting just the melatonin receptors. And many of these the benzodiazepines will actually decrease the REM sleep, where this melatonin does not decrease the REM sleep. REM sleep is essential for the brain to rest and to be able to function better. Adverse effects of this are drowsiness, dizziness, fatigue, headache, nausea, suicidal ideation, the same as the others. It can be used as an anti-anxiety drug. So your text does quite a bit on anesthetics. I'm just going to cover briefly because you don't need to know everything, but you need to be familiar with them, how they work. They are classified as general or local. Local is to just like an injection or topical to a specific site, and a general is anything that is systemic. Anesthetics can be given by inhalation, intravenously, topical, local, and spinal. I'm not sure how, I didn't put that slide in the right place. Anyway, just picture of holding somebody doing the spinal anesthesia. Okay, so you have a table 21.4, talks about the stages of anesthesia. The analgesia that they'll give ahead of time, usually like a Versed or something to relax the person and get it started, and then they give the gas. It's a very short induction where they get them down so that they can intubate them, and usually in the stage 3 is where they're doing their surgical procedure. Rare that you go into the stage 4 for medullary paralysis. These are names of some inhalation anesthetics. I don't need you to know the names of these. Just being familiar with them, and here where they use a combination, where they give a barbiturate, an analgesic, a muscle relaxer, pancuronium, and while they're given the gas, of course it's going to cause respiratory depression. It can cause hypertension, dysrhythmia. Negative hypothermia is always a risk with any anesthesia, but that's like a disorder that is passed in the family line, so anesthesia does the asking of whether there's this family history. Anyway, so I don't need you to know these, just to know the combination and have an understanding of what telling the patient the sequence of events. Okay, so intravenous analgesics. I'm seeing more now where there's nurse anesthetists are doing what we used to call IV sedation or conscious sedation, but as a registered nurse, you may have training in doing conscious sedation with midazolam, which is Versed, so you should be familiar with it. Or you may administer this and they'll come along with the propofol. If you've been around any surgery when you are, that white drip, that's propofol. It has a very, very short half-life, but it's it's an induction of putting them out, or just for a surgery where they need like what they call monitored anesthesia care, or a MAC, or they might just use excuse me, Versed or midazolam and propofol, and they'll use things like that for a procedure, sometimes putting a pacemaker in, or they'll use them for EGDs and colonoscopies, procedures like that. And then these others are to put them down further, but you don't need to know these, but I'd be familiar with these. Anesthetics can be topical, local, or spinal. Some of the things that are in the local you might find in a topical, where a topical can be a solution, liquid, spray, ointment, cream, gel, or powder. Decrease the nerve ending. Sometimes you might be places where they actually have a spray, especially when you're drawing blood on a child, to numb the area a little bit. I've even seen it sprayed on to numb it a little before they actually inject a local anesthetic. Now the local anesthetics are injected. They can be injected on the topical surface for sutures and things like that, or they can be injected to block a nerve, like when they're going to do a nerve block on a digit because they're removing a nail. Table 21.6 just talks about some local anesthetics. You should be familiar with the names such as Procaine and Lidocaine, Prilocaine. If you notice, every single one of them end in the cane. What you will see the most is lidocaine, which is a moderate acting 1 to 3 hours. I've seen some places that use the Procaine, but really you're going to see the lidocaine and prilocaine used the most. So you see here where it talks about using them for the moderate acting, for nerve blocks, infiltration, epidural, spinal anesthesia. Okay, so on spinal is local anesthetic is injected into the subarachnoid space, and the side effects can be respiratory distress, headache, hypotension. And just be familiar with the different blocks, the spinal, epidural, caudal, saddle. Spinal is in the subarachnoid membrane, as I said, and epidural is local anesthetic in the outer covering of the spinal cord. The caudal and saddle, don't worry about too much, but you should understand the difference between spinal and epidural, especially when you're teaching and monitoring your patients. So nursing interventions, of course, are any type of anesthetic received, their level of consciousness, their respiratory rate, their ability to maintain their airway. Are they having arrhythmias or too slow of a heart rate? Are they having an allergic reaction? Is their bladder kicked back in? Are they perfusing well enough to get 30 cc's of urine an hour? If you ever work recovery room as they're waking up, you do have to give analgesics. You have to be very careful as they're coming out of anesthesia on how much you give. And that's, one more. Nursing process. Page 302, your chapter ends with the nursing process. You'll just look over that. It's pretty much what we've been covering. And I think I've already said these things, but you should look over it and be familiar with it. And that is the end of this chapter. And you'll have one more, chapter 22, on anticonvulsants.